Thank you for that update. And I don't see anyone from OASF on the line. Maybe they'll hop in after the fact. Sometimes, you know, people come in later, so that's totally fine. So right now we're just going to kind of agenda hop a little bit. Today's speaker, or this month's speaker, I should say, is actually one of AHI's own. She's also very familiar with the North Country Initiative PPS, which Fort Drum is a part of. And this is Jolene Munger. She's our Provider Engagement Manager of Practice Transformation here at Adirondack Health Institute, and is very well versed in the world of DSRIP. So she's going to present today on obviously a very important topic. I would say probably 90% of the people on this call are involved in DSRIP in some way. And believe it or not, telehealth can be integrated into DSRIP and used as a way to help meet some of its milestones. So she's going to speak a little bit about that. So I'm going to turn it over to her, and she's going to share her screen. So hopefully everybody's able to see her presentation when it comes up. Yep, I can see it. Okay, perfect.
So like Katie said, my name is Jolene. Just a very brief background. Before I came to New York and started working on DSRIP, I worked in Kansas for several years doing telehealth, which is would be what is remote monitoring in New York. So I have a little bit of that background as well. So briefly, for people on the phone that are not familiar with DSRIP, it's the Delivery System Reform Incentive Payment, and the intent is to restructure New York State Medicaid program and reduce avoidable hospital and emergency room visits by 25%. We are currently in year 3 out of the 5-year program. AHI serves for DSRIP 9 counties. We have Clinton, Essex, Franklin, Hamilton, Warren, Washington, part of Fulton, part of Saratoga, and we share St. Lawrence County with NCI. So some of the DSRIP principles are to be patient-centered, transparent, collaborative, accountable, and value-driven. So we want to provide better care for a lesser cost, which is where telemedicine can make a huge impact on several of our projects. So DSRIP, it's not about launching just 10 or 11 projects. It's not about ticking boxes. It's about fundamental restructuring towards a system that really values rewards value. And it just shows, especially in the North Country, how creative we can be with hitting our goals for DSRIP. So the point of DSRIP, I mean, Medicaid spending was, as you can see, a very large amount in 2014, and the healthcare is just projected spending to grow. And New York State also has higher hospital admission rates, longer lengths of stay, more hospital outpatient visits, and a slightly higher emergency department use compared to the national average. So everybody, not just the Medicaid beneficiaries, are affected by DSRIP, because as practices and organizations put DSRIP principles into play, they're doing it across their patient population and not just for the Medicaid beneficiaries. So where patients' access to care and where they receive services will remain in service today, and hopefully increase the amount of services that they can get at that location. So this is a list of the AHI PPS projects, and we do share several in common with NCI, but this is just a list to show all 11 projects that AHI participates in. And this next page is the NCI project list. So in common, we have the first one, QAI, which is the Integrated Delivery System. We have QA2, which is the PCMH model. We have QA4, which is creating a medical village with existing hospital infrastructure. We're both in QDI, which is the PAM project, engaging the Medicaid population. 3AI, which is integrating primary care and behavioral health. And then we are all both in 4A3, which is strengthen mental health and substance abuse resources, and 4B2, increase access to preventative care in clinical and community settings. So instead of going through all of the projects, what I did is I pulled out each project that telemedicine could have an impact in. So the first one is QAAdvancing primary care. The objective of this project is to transform all safety net providers in primary care practices into an NCQA 2014 Level 3 patient certified medical home or the advanced primary care model. Challenges to this is there are multiple demands on the primary care providers with meaningful use, different quality measures, PCMH, all of the DISRIP ones, if you're in an ACO. Everybody has slightly different measures, and trying to get the providers to do them all can be a challenge. And preventative visits, access to getting access just to see your doctor, patient compliance, getting accurate demographics for your patients. There are a lot of challenges with getting in for preventative visits. So how telemedicine can potentially help patient-centered medical home is through the use of remote patient monitoring. And this is where the patient is doing the monitoring at their house, and the results are transmitted to either the primary care provider's office themselves or to another agency that has an RN monitoring their vital signs, and then that RN will transmit the necessary readings to the primary care provider. So it can be used to help self-monitor chronic conditions on a daily basis, and then they're transmitted to that nurse for real-time health interventions. This can reduce the need for urgent care visits or ER usage depending on how quick an intervention can take place. A lot of common ones, the conditions are diabetes, COPD, congestive heart failure, hypertension, hypotension, for some of the big ones in our region. QA4 is the medical village, and the objective of medical village is to reduce excess bed capacity and repurpose outdated or unneeded inpatient hospital infrastructure into medical villages by creating integrated outpatient service centers to provide emergency, urgent care, as well as access to a range of outpatient medicine needed within the community. So several challenges to this across both PPSs are the lack of funding from the state for the project, because as you all know, it takes money to redo hospital space with the construction. And then staffing the medical villages. You have to be able to, you have to get your CON from the state to decertify your beds, and then you have to be able to staff whatever new services you are going to be creating. Telemedicine can be used to deliver services as part of a medical village. So if the hospital is the originating site for patients requiring specialty care, but would otherwise need to drive long distances for an appointment, so a hospital could create a telemedicine suite where they have a room for patients to come in, and they can have a variety of specialists on the other side with just the one suite that can help provide that service. Say your area doesn't have a dermatologist or an endocrinologist or any number of specialties. They can be used to do that. Another one is the stroke carts. There are several larger hospitals that will have a telemedicine stroke cart. So when somebody comes in and is having a stroke, they can call up on the cart and get the advice right then and there through the specialist. QB8 is the hospital home, and this one is specific to AHI. This is the implementation of the Interact-like program. So interventions to reduce acute care transfers in the home care setting to reduce the risk of hospitalizations for high-risk patients. Challenges with this project are the lack of strong medical neighborhoods, communication with primary care providers, and the need for consistency in process against home care agencies. The big one for this is going to be that remote patient monitoring again. So this project really takes into play the home care agencies that get the patient right after discharge and how effective they can be with helping to monitor their patient's vital signs within the critical 30-day period after discharge. There was a great presentation by HCR at the summit or telemedicine conference about how they have been able to put that into play for their organization and then use it to help reduce the cost associated with going out to that patient's home. So it can reduce the need for the urgent care visits and the ER usage while still having a registered nurse manage the vital signs on a daily basis. 3AI is the integration of behavioral health, and this is another cross project. So the objective is to integrate behavioral health and primary care services to ensure coordination of care, identify behavioral health needs early, and ensure treatments for medical and behavioral health conditions are compatible and not counterproductive, and to destigmatize treatment for behavioral health needs. Challenges are access to behavioral health primary care resources, and then regulatory concerns, DOH versus OMH, depending on the type of facility that you are in. There are definitely challenges with recruiting behavioral health providers and primary care providers in our rural area, and telemedicine is a way to help bridge those gaps. So telepsychiatry can be utilized to integrate the behavioral health into primary care, especially in regions where you just can't support having a full-time behavioral health provider and a small primary care office, or have somebody willing to drive to your area. So this allows patients to go to their primary care office where they're comfortable. They don't have the stigma of actually going to a mental health provider. So if anybody asks, I'm just going to my doctor's office, they can go in and get the care from the psychiatrist, which can also help practices, especially pediatric practices, that are not comfortable monitoring the medications that some children get put on after they are discharged from an inpatient stay. 3BI is an NCI project using evidence-based care to manage cardiovascular disease. The objective is to implement evidence-based programs and strategies to improve the management of cardiovascular disease in ambulatory and community care settings. Challenges with this project are there are multiple demands on providers having EHR templates and collaborating with community programs. We have a lot of small practices with limited resources, and then turning standardized protocols across the region into action plans. So home blood pressure monitoring, one of the milestones or tasks for this project is to have patients keep a self-monitoring log and giving them the resources to be able to do that, and encourage them to come back into the office with that log, and then having a way to document in that patient's chart what their log is. So using the remote home monitoring, if a patient has a blood pressure machine that can transmit to a system, it can you can have that electronic record, so it's less on the patient to remember to actually write it down correctly and bring it in, but it can transmit, and then the provider can see real time, hey, does my patient need to come in, or is the medication I put them on working accurately, are they not taking it, do I need to do any changes with it? 3CI is another NCI project, and this is using evidence-based care to manage diabetes. The objective is to implement evidence-based programs and strategies to improve diabetes disease management in ambulatory and community care settings. Challenge, again, this is another demand on providers, and there are a lot of small practices with limited resources. So there's a few different options for this one. NCI had a certified diabetes educator grant, and so they look at it as part of their toolbox. The CDE is able to see patients at that patient's practice, so the CDE is at their location without either one needing to be able to travel. So if a practice has a patient that needs diabetes counseling, it's at risk, or just needs that little bit extra care, they can hook up with the CDE through telemedicine and still get that care that's needed in an area that wouldn't be able to afford their own certified diabetes educator. Another part is with telemedicine is that you can see an endocrinologist for your follow-up visits in your primary care office. So diabetes are a big portion of hospital readmissions and readmissions, and preventable admissions. And getting a foot screen or an eye exam or your HbA1c are some of the things that DISRIP is working to increase patient compliance with, and having the ability to just go to your primary care office instead of driving up to potentially an hour to 2 hours to see an endocrinologist can increase compliance on the patient's behalf. For diabetes care, the average activities of daily living score for patients using telemonitoring was 72.2% compared to 70.4% for those using who didn't use the technology. I think that was in 2014. So another one, 4B2 chronic care. So this one is cross PPS, but the milestone I'm going to reference is specifically one that I know that AHI is doing. So this is to increase access to high quality chronic disease prevention care and management in both clinical and community settings for COPD. Challenges are competing demands on physician time and access to telehealth resources in remote areas. So for this project, milestone 3 is home monitoring equipment is acquired and fully deployed. So AHI is utilizing the public health department implementation of telemedicine to meet this milestone, and information from the equipment is being transmitted to a public health nurse. They're finding that even patients who don't have the immediate connectivity due to lack of Wi-Fi or internet seem to be more compliant with treatment adherence when they have to log in and use the device daily. So this is something that we have actually put into place and are using as a way to meet district milestones and get the technology and the services to areas that otherwise wouldn't have it. Are there any questions?
I don't see any that popped in, but if anybody has a question, all right, we do have one. Phyllis, I'm going to unmute your line, so whenever you'd like to speak, put in your audio pin.
Hi, this is Phyllis. Can you hear me?
Yep, we can hear you.
Oh, yep, that works. Okay, this is Phyllis from Community Partners of Western New York. Do you have any? Do you have examples of districts that are using telemedicine for these purposes?
We have a couple of practices that have just started to implement telepsychiatry for the 3AI model. And then we have for 4B2, the COPD one, we do have practices, the health department has installed equipment into patients identified through the COPD project that are currently using the equipment. And I know for hospital to home care, there's several partners that project manager is working with to implement telehealth programs for that as well.
That's great. We have been trying to get the telepsychiatry project going in Chautauqua County, and we've run into a lot of barriers, especially with reimbursement. Since this is not a reimbursable service right now, the providers are reluctant to start something that wouldn't be sustainable in the long term.
Are you saying the home visits aren't reimbursable, or just general telehealth?
General telehealth.
General telehealth is absolutely reimbursable. Of course, it depends on what specialty or modality or article clinic you are, but it certainly is reimbursable. Is the reimbursement ideal? Not necessarily in all situations.
Right.
But Medicaid fee-for-service is certainly comprehensive in what they'll reimburse. The home monitoring that they reimburse isn't that great.
Right.
But, you know, a lot of providers don't bill for it because the reimbursement isn't that great.
Well, that is, I mean, even if they were to be paid for some part of it, they still, they're not, the payers don't have they've worked with the payers in the areas, and they don't reimburse.
Yeah, the private payers, I mean, I know it's different on your side of the state versus ours, but, you know, obviously the private payers by law are required to cover telehealth for the parity law that was enacted several years ago, but how much they cover is a different story. And as we all know on the line that we don't have coverage or payment parity yet, not sure when that will happen. But, you know, a lot of the private payers, it's hit or miss. I've been doing some extensive research myself. This is Katie, for the payers on our side of the state to kind of put on some sort of webinar to bring people up to speed. And it's very difficult to find any sort of actual dollar amount, let alone a policy.
Right. And it's you know, we have engaged primary care practices that really would like to offer this service, but they just can't make it fly. They've worked with the payers, and they've gotten a direct, we don't cover this service, you know, response.
I'd be interested to know who's saying, what private payers are saying they don't cover it, because by law they have to.
Okay.
So maybe offline send me an email of what payers are telling you that, because that's interesting, because by law they have to cover it.
Okay.
And also you're absolutely right in terms, you know, if anybody on the line attended the Regulatory Modernization Initiative work groups on telehealth in September, the comment was made, and I don't remember who made it, that telehealth does not follow the dollars. And many of us on these calls are mission-driven people, and what's happening more and more is that programs, you know, such as yourself or other practices or hospitals are deciding to move forward and just implement some sort of telehealth, even on a small scale, just to create that access point, even though they know it might be a loss. And that's unfortunate, because that's not what we want. That's not how we create sustainability, but we're kind of we don't have a choice anymore. As, you know, as this becomes more and more prevalent in the healthcare world, more and more practices are reaching out to me and to Jolene alike, saying, you know what, we just have to implement telehealth. It was not our first choice because it's not sustainable right now, but our patients need access to care, and that's more important.
Right, and you know, we can use the power of district to be able to launch some of these things, but we just have not. We've run into many barriers. So yeah, it would be great to talk with you offline and see where others have had successes, and maybe there are ways that we could glean from other successes.
Yeah, I'll reach out to you. I also have another question from Sarah Bollinger. She asked if, you know, how does home monitoring work in areas where there's not good broadband? So every software or provider for the telemedicine monitoring has their different ways of connectivity. The one that I am familiar with that I used when I was out in Kansas you could either hook it directly into a landline, or you could hook it into a cellular data device. We find typically that people that don't have, you know, cell phone service still have a landline, so they can hook into it that way for the data to transmit. Yeah, and I would reiterate the same. I work with a couple of different vendors, and typically the best connection is Wi-Fi, especially in an area where there's no coverage. But in the event that a patient does not have Wi-Fi in their home, or even 3G or 4G, sometimes we have to bring it back, quote unquote, old school, where we use IVR lines, integrated voice response, where a patient would call in their metrics. That is still technically telehealth. It's not maybe the definition that we all know, but it is a way for a patient to at least, you know, call in their metrics and, you know, hit their daily measures that they need to hit. I do see another question from Andrew Solomon. Andrew, I unmuted your line.
Thanks, Katie. Can you hear me? I thought I'd just comment on the first question, and I think the first question was focused on remote patient monitoring. And Katie, you mentioned the law, and I don't believe remote patient monitoring was included for private payers in the law. It was included for Medicaid, but not for private payers. And I'd be curious, and I missed the name of the person who asked the question, but I'd be curious if she or if you or anybody else has approached any of the private payers specifically about pilots. It seems like payers are more interested or are becoming more interested in hosting pilot programs in general across the region, and I'd be curious if anyone's approached payers in New York with that idea.
So funny you asked that. This is Katie. I had a call with CDPHP this morning. Very timely. So my reason to reach out for them was very much what you just said. I'm trying to do some real research into, where are your policies located? How do you reimburse? What are you looking at? So right now, CDPHP has a number of things going on. If anybody remembers from, I think, October's Learning Collaborative, at the last RMI meeting, it was announced by the state that they would be allowing Medicaid managed care plans to submit telehealth innovation plans to include what they call in lieu of services, ILS. So basically, a Medicaid managed care plan could submit what's called a telehealth innovation plan to include the patient's home as an originating site as part of their offerings to their members. So right now, they are in the application phase. Applications are due December 1st. CDPHP is applying. They did not tell me specifically what they're looking to add, but them and a number of other private payers that offer Medicaid managed care services are applying to add services that would include telehealth. So we won't see federal approval for this until April, as I was told, but if you plan that out for next year, we're probably looking at the second or third quarter before we'll see approval or announcements from plans about what they were or were not approved for. But I know CDPHP is looking to add some value-added services around telehealth to their existing policy and procedures. So, as I find out more about that, I'll communicate that to the group. They definitely want to carefully plan for the future and are looking at home monitoring. A lot of private payers have obviously different policies for what they will and will not cover. Very few, if any, cover remote patient monitoring. So you're absolutely correct. I'm trying to do my research on that, so more to come. And there was one last question regarding home monitoring and how do you educate the patients to use the unit so as not to put more on the providers or staff?
So just from my past experience, so the company that I worked for, that was all we did was what's considered remote patient monitoring here. We were covered underneath Kansas Medicaid as a reimbursement, so most of our patients were Medicaid over 65 because they had to be on a certain waiver, and we also had patients out of the University of Kansas Medical Center, their congestive heart failure unit. So what we would do is we would send out somebody, occasionally it was myself, to the patient's home and install the equipment, and we'd go through, show them how to use the equipment, have them do a teach back, and then within a week we would send somebody back out to their house and just have them run through it all again just to make sure that they had the understanding. If a caregiver was available, we would train the caregiver or a family member on how to use the equipment as well. So that way there was somebody else if they had help. If there was an issue with the equipment, then they could call in, or if we noticed that they hadn't taken their readings for the day, we would call them and see if there was a problem, if they just forgot. So it was really just making sure that you do proper education. You take the time when you go out there to set it up, and you can leave instructions on how to use the equipment. But most of it it's pretty easy equipment to use, and they're used to doing it. So most people know how to put on a blood pressure machine, and some of them are now switching just to a wrist cuff, or the full arm. So it depends on the equipment that you have. The COPD ones are pretty easy to do because it's just putting that clip on your finger and pushing, a start button. the diabetes, most people have their own glucometer, and that you don't typically have to change your glucometer, so that's not something. And then the other main piece of equipment is using a scale. So it's getting a scale either that's with handlebars on it that they can transfer, or getting one that walkers can roll over, so you don't have the risk of the patient falling when they transfer from the floor to the scale.
Yeah, and I have a vendor that I work with that created a patient telehealth teaching checklist, and they have their, you can use provider as a blanket term, but typically it's a visiting nurse. And they go through, it's like 10 yes or no questions. You know, is the patient or caregiver able to turn the monitor on? Can they get to the welcome screen? Can they take their measurements correctly? Can they read the questions on the daily how are you feeling questionnaire? Is the patient aware of who to call in the event that they can't figure something out? Is the patient aware that this is not to be used for emergencies? Is the patient aware of, you know, how to operate it? Very basic questions of understanding that most vendors would provide you with this checklist, or, you know, you could internally create your own based on what patient population you're working with and what works best for you. You know, not every patient is going to be a good fit for home monitoring, and I've seen that firsthand. I'm sure Jolene has as well, and that's okay. You know, maybe somebody needs a little bit more hands-on, but I mean, I've seen 88-year-old patients use different platforms, and, you know, it's prevented numerous ED visits or urgent care visits. So it certainly has a use case for that. And then I don't see any other questions that came through. So thank you, Jolene. That was super informative. And I think the home monitoring piece is really important and seems to keep coming up more and more. So thank you for sharing your knowledge and expertise on DISRIP.
Hey, Katie, I just, one comment. This is Corey on the home monitoring. Keep in mind that your ROI for implementing a home monitoring may not be a direct reimbursement, but if you're providing home health services, like you're deploying to public health, or if you're hiring care managers to follow up on the patients, those blanket or bundled payments to care for that patient can be offset by the savings of home monitoring. So you may be able to expand your ratio of caregivers to patients, or patients to caregivers rather, utilizing home monitoring, you know, for a better patient experience and a more economical way to kind of expand those services. So that in itself may help to offset or completely offset the cost of the home monitoring program without having to directly deal with reimbursement.
Yeah, thank you for that. So I do see someone from Oasis on the line. I'm going to unmute your line, Carmelita. If you would just, if you don't mind speaking for a few minutes on the update that's coming from your department. You'll need to enter your audio pin to speak.
Hey, it's Carmelita. Can you hear me?
Yes.
Okay, great. So I'm not sure what update Sarah was supposed to deliver on this call, and I know that she couldn't get on. Our regulation was published last month, so it's out for public comment right now.
Yeah, that was what I was referring to. Sorry.
Okay. All right. Great.
Yeah, basically what Sarah and Deborah talked about at the telemedicine conference is kind of the same update because a lot of the folks on the line here weren't at the conference.
Okay, so the Telepractice regulation is out for public comment right now. I think it's out until mid-December. It's posted on our website, so if you go to oasis.ny.gov and go to the regulations section, it's Part 830. There is a both draft regulatory language and a standards document that goes into a little bit more detail on certain things, such as, you know, the kind of equipment that you have to use and you know, how to kind of file your application for approval. So those things are posted on our website right now. I'm not sure what other updates.
That was really it, just to make people aware that OASS has published draft regulations, and if you're one of those clinics, definitely need to go ahead and take a look at those. And I'll send a link out to that website that Carmelita just referenced in the notes email that I probably will send out tomorrow.
And if anyone has any questions, you can contact us at legal@oass.ny.gov.
Thank you. No one from DOH is on the line, but I can give a brief update based on what they talked about at the North Country Telemedicine Conference several weeks ago. They did share some slides, so if anybody would like to see those slides, please reach out to me if you weren't at the conference and want to check those out. But basically, next steps for the Department of Health are that, and I'm just reading this from their slides that they sent me. I'm not speaking on behalf of them. They're publishing a Medicaid update article outlining the expanded telehealth coverage and reimbursement policy. Currently, the draft article is circulating for review. I know that most people on this line are looking forward to that. They are amending the radiology regulations to allow teleradiologists to bill Medicaid, and they're publishing a Medicaid update article outlining the teleradiology policy. Lastly, they are resubmitting SPAs to further expand store and forward technology and remote patient monitoring. SPA approval was previously obtained for these applications, and they are going to be reviewing the existing fee structure for reimbursement of home monitoring, so hopefully that fee will increase. So that's what I have from DOH in terms of what they presented several weeks ago. Hopefully on the next call, we'll hear from them. So moving to the last part of the agenda, is just an update from myself and Bob Hunt. I'll just start with a brief overview of the telemedicine conference. It went very, very well for those of you on the line that attended. I hope you found it valuable. We received really great remarks. I do know for next year if I bring back the state folks, to give them more time to speak, because that was certainly some dynamic dialogue. And keep in mind that next year we're looking to move to a different venue to accommodate more folks. I know that not everybody was able to attend because we did sell out so quickly, so we are definitely keeping that in mind and changing location for next year. Still going to be in Lake Placid, but in a bigger venue. And the other big update is involving the Learning Collaborative. So historically, we've done that on a monthly basis. We are going to move to an every other month format, just so that we can create a more robust agenda, more easily find speakers, and make sure that we're not badgering our friends at the state for updates every month when they don't always have them. So the next Learning Collaborative will be on Monday, January 22nd. So there will no be December meeting, and we will be sending out either new GoToMeeting information or updated information for you to check that out. If anybody on the line has ideas for speakers or would like to speak themselves, please let myself or Corey or Bob Hunt know, and we'll take a look at your idea and see where you can get fit in. We do have a speaker lined up for January already, but are certainly planning out the rest of 2018. So let me know. And if anybody has thoughts or feedback on the conference, please let me know about that as well. Bob, did you have any updates from your side?
Nothing for today's call, but we should have something for the next one.
Okay, fantastic. That wraps everything up. There's no other questions, so we'll go ahead and end it a little early for today. So thank you everybody for attending, and have a fantastic Thanksgiving.